Good morning. We're reporting from the International Stroke Conference here in Honolulu. I'm Seemant Chaturvedi, stroke neurologist from Wayne State University in Detroit, and I'm interviewing Dr. Paul Vesa, who's Director of Neurocritical Care at UCLA Medical Center. And I'm asking Dr. Vesa about the ISIS trial. And so, Dr. Vesa, maybe just give some background as to what were the current treatment options for intracerebral hemorrhage, and what are some of the thoughts which led to the ISIS trial?
Wonderful, yeah. The current options for intracerebral hemorrhage are either open surgery, craniotomy, or medical management. Mm-hmm. And the Stitch 1 trial, as we all know, came out years ago showing that open craniotomy may not convey a benefit, especially for deep hemorrhages. And so we've been trying to address the concern for deep hemorrhages and trying to evaluate whether minimally invasive surgery will actually improve outcome for these deep hemorrhages.
And there may be many general neurologists or intensivists who don't have that great knowledge about what exactly is entailed in minimally invasive surgery. So could you describe that for us a little bit in terms of how that was conducted in the trial?
So this trial is an endoscopic surgery trial where we take a high-resolution CAT scan that allows neuronavigation so that we can stereotactically go deep into the hematoma itself, right into the hematoma with an endoscope. The endoscope's about an 8 millimeter diameter scope. Mm-hmm. So we don't really open the skull up very much. It's a small burr hole. Mm-hmm. Go into that hematoma, go into it in a specific trajectory, and then suction out the hematoma. And most of the hematoma comes out with that procedure. So it's a short operation, it's minimally invasive, and it really uses technology to really guide the surgeon.
Mm-hmm. And in terms of the types of hemorrhages which were included in the trial, were those all supratentorial, and did they include typically basal ganglia, thalamic, or were cortical hemorrhages also allowed?
So these were all supratentorial hemorrhages. They were all either lobar or deep basal ganglionic hemorrhages. There was kind of a 50-50 division, and there were both left-sided and right-sided, so we didn't discriminate between the dominant hemisphere.
Okay. And what were the major patient exclusions for the study?
So we excluded people who were either too old for our study, for the purposes we're 80 years old, mm-hmm. small hemorrhages, less than 20 cc's in volume, mm-hmm. Patients who were deteriorating, the hemorrhage was growing over time, and were deemed to be unstable, or patients who had an AVM, an aneurysm, or some other kind of vascular anomaly that was the cause of the hemorrhage, because we didn't feel it was safe to operate on those patients.
Okay. And were warfarin-related hemorrhages also excluded?
Yeah. Well, warfarin hemorrhages were actually included if we could correct their INR, but by and large we didn't really have those patients in the study. Yeah.
Okay. And what about if there was intraventricular extension of the hemorrhage?
So if there was a small amount of intraventricular hemorrhage, that was permitted into the study, but if the ventricles had a large amount, then they were actually excluded because they're part of a different type of study, and we didn't want to confuse the two types of studies, the CLEAR study and the ICE study.
Right. Okay, and why don't you tell us about the number of patients enrolled, number of centers, and some of the principal results?
Great. So we had 7 different centers. It was a multi-center study, academic medical centers. We enrolled 20 intention to treat study patients. We had 24 overall because we had some run-in numbers. What we've achieved was good surgical compliance with the protocol. The evacuation was pretty good. We got about 70% of the hemorrhage out by the surgeon. Mm-hmm. There were really no surgical-related deaths, no real kind of huge expansions of the hemorrhage. Mm-hmm. We had pretty good results in terms of safety, not a difference in terms of adverse side effects or serious adverse side effects between the two groups. Mm-hmm. And mortality was lower across the board at multiple time points in the surgical arm. And to our surprise, our pleasant surprise, the modified Rankin scores were better in the surgery group than in the medical group. So we're very excited about these preliminary results. It's a small number of patients. It's preliminary, but we're very excited.
Okay. And the judging of how much hemorrhage was evacuated, how many hours after the procedure was the CAT scan done?
So the CAT scan was done immediately after surgery, and then it was done daily thereafter.
Okay.
And the hemorrhages don't come back, so they don't reoccur, in a delayed fashion.
Right. Okay. And what would be the next steps for you and your investigative team?
So we're planning ICES-2, the second study, where we're going to try to expand to 100 subjects so that we can better refine the surgical technique, train more surgeons in this technique to get them up to par as a phase 2 additional safety study. And eventually we'd like to have a phase 3 study to be a definitive pivotal study.
Okay, well that's terrific and very encouraging news for the patients who we encounter with cerebral hemorrhage. So I thank you for all your work and congratulate you and your team.
Thank you very much. Thank you for the opportunity to share.
Thank you.